This recording will go over thrombocytopenic disorders. So just a refresher, what is thrombocytopenia? It means low platelets, so less than 150,000. Remember, normal platelet count is 150,000 to 400,000. Platelets are responsible for clotting, so if they're low, the patient has increased risk for bleeding. Some signs you'll see clinically include petechia, purpura, easy bruising, and bleeding. It could be mucosal bleeding of the gums, nose, GI tract. It could be bleeding at IV sites. Basically, the job of platelets is to plug up holes, and if we don't have platelets, we can have leaks, which is actually bleeding. There are 3 thrombocytopenic disorders that we're going to focus on. The first one is immune thrombocytopenic purpura, which is a bleeding issue. The second one is thrombotic thrombocytopenic purpura, which is a clotting and bleeding issue. And the last one's a unique one, heparin-induced thrombocytopenia, which is actually a clotting issue and doesn't really have the bleeding concern with it. But all 3 disorders lead to low platelets. Their mechanisms, risk, and treatments are different. The first disorder is ITP, immune thrombocytopenic purpura. It's an autoimmune disorder where the body destroys its own platelets in the spleen. Bone marrow is normal, production is fine, but destruction is the problem. ITP causes platelets to drop, so the problem is bleeding. There are no clotting symptoms. Signs and symptoms of ITP would be signs and symptoms of bleeding, so petechia, purpura, easy bruising, bleeding gums, heavy menstrual cycles. So remember, no clotting with ITP, it's bleeding only. Treatment could include corticosteroids, IVIG, splenectomy for chronic cases. And remember, if a patient has their spleen removed, they're at increased risk for infection. Also, platelet transfusions for severe bleeding. Not a surprise, nursing priorities are going to focus on bleeding prevention. So for oral care, use a soft toothbrush, no IM injections, make sure the patient's on fall precautions so they don't hurt themselves. And we want to monitor platelets to track trends and report any drops. Remember, ITP is bleeding only, not a clotting problem. Next up is thrombotic thrombocytopenic purpura, or TTP. TTP is very different and it's very dangerous. It's considered an emergency situation. TTP is a problem with ADAM-TS13 enzyme, which leads to microclots everywhere. And ADAM-TS13 is actually an enzyme that's in the blood that regulates clotting. Its primary function is to prevent platelets from sticking together and causing excessive or dangerous clots in small vessels. So if we have a deficiency of this enzyme, we see what's listed here. We see microclots in small vessels. The platelets get used up, leading to thrombocytopenia. Red blood cells are going to get destroyed, leading to hemolytic anemia. Think of clots everywhere and organs getting destroyed. So a lot of clots in little vessels, and organs aren't getting the blood flow they need. You can think of the following 5 signs and symptoms when you think of TTP. You can use the acronym FAT-RN to help you remember them if you want to. F is for fever, A for anemia because of the red blood cells being broken down, T for thrombocytopenia, R for renal problems, and N for neurological symptoms. The renal problems and neurological symptoms show up because those little microclots are blocking little vessels within the kidneys and the brain. Diagnostics for TTP can include decreased platelets, evidence of red blood cells being broken down, and the coagulation labs can be normal. Treatment can include plasmapheresis or a plasma exchange, which removes antibodies and replaces the ADAM-TS13. Corticosteroids and immunosuppressants may also be used. Remember, TTP results in abnormal clotting and bleeding, and it is considered an emergency. The plasma exchange or plasmapheresis is a life-saving intervention. TTP nursing priorities include neural checks, monitor for confusion, headache, stroke-like symptoms. Neurological changes signal a worsening of condition that requires immediate action. We also want to check for kidney function, so track creatinine levels and urinary output. Decreased urine output is an emergency sign of a complication. Also, we want to make sure we're using bleeding precautions, monitor for petechiae and bruising, apply standard bleeding precautions alongside clot monitoring, and recognize emergency signs and symptoms, including neural changes, fever, decreased urine output. We want to make sure that the physician is aware of any changes in the patient's status so that we can have timely interventions. Our third disorder is a unique one, heparin-induced thrombocytopenia. It's an immune reaction to the medication heparin that causes platelet activation and causes abnormal clot formation. Platelet drops, but clotting risk rises. The onset is typically 5 to 10 days after starting heparin. So remember, we got low platelet levels, but high clot risk. So let's look at the clinical manifestations of HIT. Platelets will drop often by 50%. You'll see new clots, DVTs, PE, stroke. You may see skin necrosis at the injection site. Remember, HIT is not a bleeding disorder. It's a clotting disorder. Treatment includes stopping the heparin immediately and starting an alternative anticoagulant. Some nursing priorities include monitoring patients who are receiving heparin closely, monitoring their platelets, right? So we're watching for a drop in platelets, and we've already said it could drop up to 50%. We're also going to be looking for signs of clots. So DVT, signs and symptoms of PE, chest pain, and then we want to provide patient education. Instruct the patient to avoid heparin in the future if they have an incidence or an episode of HIT. Once they've experienced it once, they're going to want to make sure their provider is aware that they've had this experience when receiving heparin. Remember, HIT is when the medication heparin causes the body to be in a hypercoagulable state, so excess clots. Uses up the platelets, low platelets, excess clots. We're going to first stop the heparin and then anticoagulant with a different type of medication. This chart is a nice chart comparing ITP, TTP, and HIT. Can use it when studying. Remember, one of these conditions causes bleeding only, that's ITP. One condition causes clots and bleeding, that is TTP. And the final condition only causes clotting, and that is HIT. And this last slide is just some more memory tricks to help you memorize and remember when you go to take your exams, the difference between ITP, TTP, and HIT.